right. Hello, everyone, and thank you for joining us today. We'll give everybody just a moment to get connected and verify their audio, and then we will dive in. We really are grateful that you've chosen to spend this next hour with us. Before we get started, we always want to acknowledge our sponsors. Without their support, our event schedule like this would not be possible. Our partnership with ANIA and the Arizona HIMSS chapter, we are committed to you, our members, by providing meaningful virtual and in-person education opportunities. So thank you to our 11 annual sponsors for making this possible. For those that have joined, remember that this event is eligible for your CE credits, so don't forget to log into your HIMSS profile to capture those. We are recording this session, and we will publish it to the Arizona HIMSS chapter website for future reference. And I believe we share that with ANIA, and they do the same as well. I'm Tina Burbine, filling in as moderator for our Arizona HIMSS board member, clinical leader and friend Terry Tusnick. We're touched and delighted that Terry's listening in today, and she always has an open invitation to join the discussion at any moment. Welcome to part 2 of our 3-part webinar series called Synergy in a Dyad, CMIO and CNIO Collaboration in Action. Our part 1 focused on how CMIOs and CNIOs drive measurable outcomes. If you missed our part 1 conversation, you can find the recording link out on our past events page. And we're thrilled to continue the discussion today with this part 2, which is how CMIOs and CNIOs support clinical practice transformation. We want this to be an interactive conversation, so please add your questions in the Q&A box. You'll note that that Q&A box is a little different from the chat feature. Chat's not enabled. We are looking for your commentary in the Q&A section. So let's begin with our round of speaker introductions. Candace, would you like to start?
Yes, thank you. My name is Candace Larson. I am with Honor Health. I am the Chief Nursing Information Officer.
So I'll go next. I work with Candace, so I'm Dr. Matt Anderson. I am the CMIO, the ambulatory and virtual space here at Honor Health, and get to work with Candace and our other CMIO, who covers more of the hospital and ED facilities at Honor Health.
Hi, everybody. My name is Amanda Klopp. I am the AVP of IT and CNIO at Tucson Medical Center, and I will hand it to my colleague, Josh.
Hi, I'm glad to follow Amanda. So I'm Josh. I'm the Chief Health Information Officer for TMC Health. And our structure is that includes the entirety of our health system. And we should hand it off to another institution that I don't know.
Yeah, that's I'll take it from here and then
Okay.
and I'll bring it over to Steve. So I'm Mike Jones. I am the Vice President and Chief Clinical Informatics Officer for the Central Region at Common Spirit Health. We know the local brand as Dignity Health within Arizona. And then Dr. Steve Leach is with me. He is my dyad partner, and I'll let him introduce himself.
Good afternoon, everybody. My name is Steve Leach. I'm the CMIO for the Central Region of Common Spirit Health. Sorry I'm not on the camera with you. I'm mid-travels and can't get on the camera, but I'm glad to join you by phone.
Thanks, Steve.
Yeah, appreciate all of you being here. You know, since it's early in the year, 2026, we're still in January, why don't we start by each organization talking about what their clinical practice transformation goals are for the year ahead. Candace and Matt, would you like to begin?
Sure, absolutely. It is definitely a collaboration with Dr. Anderson and Dr. Norquist, but also as part of our transformation office. We have other sister departments such as IT, EPMO, data analytics, and marketing and process improvement. So we do strategize and are creating a ongoing roadmap of our goals for the organization, but as wholly as a transformation office. And then kind of drilling down a little bit more from a clinical perspective, what are those strategy and goals that are going to impact our caregiver experience primarily? We're members of the Class Arch Collaborative, so we're very focused on those action plan goals that are set forth for us. But collectively, we are really focusing on AI, road mapping that with our analytics team, but also taking a look at AI literacy and what that means to a clinician. So it's a very big bucket of work that we're working in that realm. A lot of effort in our virtual care, expanding current state what we have, and Dr. Anderson can kind of touch on that in terms of telemedicine. But in the nursing space, we are continuously expanding our current program, and then also strategizing how we can deploy to our other sister hospitals and units, and coming up with that plan. And then also with the caregiver experience lane as well, we're looking at tools and features and functionality to make our workflow for our physicians, our APPs, our nursing staff, and our other clinicians much easier, quicker. Looking at technologies such as AI summarization that many of us have in our EHRs today, as well as some other third-party complements to support that strategy, such as ambient voice. So I'd say at a high level, that's kind of what we're doing. And then lastly, we're also kind of in the innovation space in terms of looking at road mapping our patient room of the future and what that looks like, and even looking at the clinic spaces too. There's definitely opportunities. So a lot of great ideas are put on the table. It's about prioritizing and how we want to make that look like here at Honor Health moving forward. Dr. Anderson, I know you probably touch a little bit more on your world for the folks, so I'll turn it
Yeah,
over to you.
absolutely. Yeah, I think we definitely have some of our own New Year's resolutions. Like everyone, we have to talk about AI in every meeting. That's number one. So we have to do that. But I think really thinking about how we're going to make sure that we're using AI in a positive way that makes a difference. If we are just doing some things just to make things a little bit faster, or throughput just a little bit better, I don't know if that's what we're really focusing on. It's really how to make an impact. Like Candace had said, ambient AI for documentation across the spaces. So whether you're talking about an urgent care, an ED, an oncology office, a primary care office, on the floor, for nursing, for clinicians, for everyone, I think that's going to be one of the biggest focuses for this year, is being able to just give that opportunity for everyone to unburden themselves from sitting and typing, or using some sort of direct speech to text. I think that's number one. And then the other one is just continuing to bring healthcare to where our patients are. How do we leverage the tools that are most needed in the home, where they're at work, wherever they are, to make sure that they're getting the right care. There's a lot of white space in between building-based visits, and we can fill that in with technology. We can fill that in with conversation. We can make sure that we're kind of covering all of that space. And so I think those are probably the two biggest things that we're going to be focusing on, is just bringing that care to the patient, and then leveraging that passive ambient AI to make everything a little bit easier for our clinicians.
Uh, Maybe we can continue to go in the same order. Amanda, do you want to kick it off, and then I'll bring it on home?
Sure. I would say we are also focused on AI. It's in most of our conversations, really looking at the care model evolution for reduction of cognitive load with both ambient and some of our automation tools. We had large success, I would say, in our ambulatory space with rolling out ambient. And so 2020, and in the ER. And so 2026 is really focused on inpatient, both for physicians, and launching that care model evolution within nursing for ambient. We're also looking at some of our operational interoperability in terms of technology that are in our patient rooms, and how we can continue to make those work for us differently and better, and optimize our frontline staff and clinician workflow with those tools. And then within the Department of Nursing, we have officially launched our Magnet journey. And so we're doing a lot of reevaluation and deep dives into some of our clinical data and outcomes. Josh?
Yeah, I would say as a companion to that, and potentially leveraging AI tools to further this, we're pretty concerned about the sort of juggernaut of financial hardship that all health systems are going to face with basically Medicaid cuts, right? I think for HR1, what's going to be the impact? So how do we begin to create financial resiliency? But interestingly, I think we're looking at it through a sort of quality revenue lens. And so we want to do an uplift on physician documentation, leveraging AI to do that better. And not just assistive AI. This note, I'm seeing this CDI opportunity. How can I bring it forward? The EMR that we use with this next release is really allowing us to do these nudges to providers. It's also, I'm, hugest fan of a Magnet Journey is how do we get interdisciplinary documentation to help further that? So we, for example, are doing a pretty big initiative with our dietary team to help better identify patients at nutritional risk in the hospital. And how can their documentation also be leveraged to improve it? Now, for people who are revenue cycle junkies, they know that as we increase charting complexity, it also makes our patients appropriately look as sick as they are, and that helps in our observed to expected mortality ratios. So I think everybody's trying to do a better job of appropriately identifying risk, and I think our TMC journey is how do we use the chart to help us on that way, but not just by 10,000 reminders, but having AI really put the most relevant information in front of the physician and other caregivers for that decision. We're also on like mega growth mode. Amanda and I are often just TMCs. We're integrating our two critical access hospitals, and that is about delivering a relatively seamless experience to patients all across Southern Arizona. And last year we added a cancer center to our portfolio with a lot of help and advice from our Honor Health colleagues. I'd like to do a little hat tip to them. They were great Sherpas on our cancer journey, and I think so. We have like quality improvement, but then this insatiable engine of growth for new service lines, and that takes up a fair amount of our time, to be honest. And we will hand the baton, I think, to our. It's hard, I will say common spirit. I'm used to dignity though. Dignity
Oh no,
always.
no, all good. What's AI? No, I'm kidding. We're talking a little bit. I know Candace had to laugh at that. We're talking a little bit around strategy and what are we looking at in our what I would consider in our near future and long-term future in healthcare in general, but when we look at common spirit and dignity, and we may have a different spin. Yes, we're looking at AI, but I'm going to take a step back. When we're in 27-ish states, 2,200 care sites, 180-ish thousand, give or take employees. We're looking at how do we, one, and this is more on the IT side of the house, so I'm not going to spend a whole bunch of time there. But one, how do we streamline our footprint of technology? And that there's a couple reasons to that. One, that reduces overhead, but two, it looks at how do we improve interoperability of patient information so that information is available at the right time, in the right hands, whether you are being seen as a patient in Arizona or you are vacationing over in Tennessee and at one of our other hospitals and need care, your information is readily available. So one, that is one of our strategic initiatives that we are zeroing in on. Two, we look really at how are we streamlining efficient practice, and that's subjective in term, right? But we are putting metrics and measures around that, streamlining practice for the clinician experience, doctors included, nurses included, but really across the interdisciplinary practice. And then when we're looking at the third big bucket, it is how are we engaging our patient, the digital front door? How are they able, within reasonable time frame and with ease, interacting with the suite of providers and tools that are available to them within the health system. So when we look at overarching our buckets, that we're zeroing in on, and then multiple projects lying in there. And I know Steve's biting at the bit to talk about a couple of them because they're fun. But I wanted to at least start off where where our eyes are landing, and then they drill in and underneath of those. And then Steve, what you got?
Yeah, thanks, Mike. Yeah, a corporation this big, it's often hard to move anything very fast, but we do have the opportunity to check many things at a time. So, in our space, we're still continuing to function on robotic process automation to lower the barrier to care for our providers. So, using bots that will use Healthy Planet and actually deliver a suggestion, a pending order for that mammogram that's not yet been done, that's delinquent. We've always been doing it with lung cancer screening and colon cancer screening for about a year now. It's got a couple of years on lung cancer screening, but those health maintenance activities that could also generate revenue, but also is best for the patient and best for us to make those show up instead of making providers have to search for them. In the AI space, really, anything we're looking at, can it increase productivity? Can it offload stress from our providers on our nurses? Can it make their jobs easier, right? And can it improve quality? Can it find a missing incidentaloma and suggest that we follow up on the incidentaloma without us having to remember or find a note somewhere that said there was a small nodule on this study back whenever, right? And then there's some other AI tools we're beginning to pilot that are looking to bring the kind of note creation and actually coding enhancement to the work site. So as a provider is in the chart and starting to work on a note, this tool will actually surface like a bibliography of references that say, hey, by the way, maybe you should be using this code that's at ACC, and here's why. One, the ejection fraction last year was this. Two, their B&P was this. Three, this is a note from the cardiologist that said X, Y, and Z. So we reduce queries, get the coding done right, and then as we write a note, the note is written in a way that insurance companies are less likely to deny it. And then finally, we were on that journey to try to get all of our sites for the next 5 years on one build of the Epic EMR. And so Mike and I will be spending a lot of time on that going forward. We currently have still 14 different EMR versions that were EMR companies inside our large company. And the idea is to go and get Cerner out of our house and get all these other EMRs out of our house and get everybody on a single build. But we even have 5 instances of Epic. So we've been good at splitting. We're trying to get to learn to luck a little bit more.
Yeah, appreciate all of hearing about all of the different transformation goals that each of your organizations have in front of you. So now, of course, I have to ask the million-dollar question, because anytime we talk about annual initiatives that we're striving to build on and change and do more together as a team, the conversation always turns to things like ROI. How do you measure it? How do you set your KPIs, et cetera? Candace, would you and Matt like to start? Or Steve, you started to jump in.
Let's have Candace kick it off.
I'll go ahead and jump in there.
Yeah.
I have a comment to the last topic, and it's kind of what you mentioned, Mike, more on the IT side of the house, but yet kind of segue into some of that consolidation effort into one system. But one initiative that we're really focused and partnered with our IT colleagues is core platforms, taking a really take a looking at our landscape and a deep effort on what are our platforms, identifying what those are, and actually having our operational leaders partnered with our vendors, kind of that triad, if you will, so that our operational lead has a full understanding of features and functionality, and then partnered in terms of what is the vendor's roadmap so that we can kind of line up with our roadmap and then be on the same page as IT. But kind of similar to what you've mentioned, Mike, is kind of reducing that, application debt, if you will, and shoring up our application portfolio management. Because that also, kind of goes downstream in terms of the resources it takes to teach our clinicians, train our clinicians, being thoughtful when new features and functions come through, that interoperability and integration that we have to be thoughtful. So the more that we can get reduced to one as much as possible, get it streamlined. That's kind of what the goal that we're shooting for is to, as well as, in addition to. So But in terms of ROI, I'll kind of say that, we often struggle with that because a lot of the work that we do from an informatics perspective is really to take a look at our clinician experience. It's really hard to measure. But we're really being challenged around that in terms of what kind of impact can we make? So it's kind of that soft ROI, I think, that we all continue to talk about. So, for example, in our virtual care, honing in on virtual nursing and sitter initiatives, taking a look at our NDNQI data, some of the workforce data, things like that, looking at turnover, falls, some of those quality initiatives and whatnot. But from a EHR perspective, we're being sought out to contribute to those metrics. So are we looking at reducing our clinicians' time within the EHR? Are we looking to shorten that documentation gap? Because that also has downstream effect in terms of clinical decision support. So we really want to refrain from a lot of data being entered towards the end of the shift and things like that. So again, just working collectively towards those metrics and making an impact as well too. One that we're really hitting home, at least with our nursing division, is our chart review time. We recognize that we have a lot of opportunity against our, other, we're on Epic customers, so against our other Epic peers. What can we do to improve that chart review time? Because obviously, that does take time to kind of get the big picture of in landscape of what is going on with my patient in those quick moments, whether it's shift-to-shift handoff, or maybe I'm covering for somebody. What are those quick ways that I can do it versus, kind of sifting through the chart? Well, yes, we're making efforts to making foundational improvements on, some of the reports and views and things like that. But again, kind of taking a look at some automation like a summarization to make it quick and easy for our clinicians. So I'd say, I don't know that I have a straight answer, but we're, definitely challenged with what is that ROI? I think we always have a tough time that say we're going to reduce our workforce, but taking a look at a different lens, like where can we do some of that time? Does that give enough time get back to a nurse or a virtual nurse to do some other tasks that we probably didn't have time or could have done?
I wanted to interject here because the TMC model of work is slightly different. In other words, Amanda and I are dyad partners, but our informatics and our IT work are totally integrated. Like it's not separated. And in fact, one of the things that's quite vital, especially as we begin to think about a capital budgeting cycle, we are called upon to create return on investment documents before we launch. And Amanda might want to reflect on roles she plays in governance, not only for our AI governance, but also her work with the sort of senior cabinet of our system chief nursing officer, because I think a lot of that gets worked out in deciding what exactly our initiatives for the year are going to be. And so lots of organizations divide stuff differently. I just want to share we're much more conjoint in that decision making.
Yeah, and I would say in Common Spirit, Mike and I are working really hand in hand. There's two teams, so we're all working the same work on different audiences, but it's all the same. It's about everyone in the company. I'd say ROI or KPI, proved by KPI, is part of everything that we do. We do measure beforehand. Sometimes that's a survey, the soft ROI. Sometimes that's an RVU measure. Sometimes that's a CDI measure, some sort of our case mix index, and we measure before and following, and we have a plan for what that means. And what we'll be doing across the 5 regions of Common Spirit with all the AI tools that Epic creates in the next year, we'll be testing them, split up among the 5 regions with hard ROI targets. And what doesn't work, we won't keep, and what does, we'll adopt more widely. But that's kind of our approach to. So it's just part of what we do. We're dealing with people in healthcare, and healthcare outcomes take years to happen. So I can't measure how many heart attacks I avoided without having years and years of measurement. And we don't have time to do framing hand kind of work. So we have to use soft measures, and that's just part of it. Mike, do you have a comment?
Yeah, so a couple things around ROI. Some, and I'm going to state the brutal obvious, and that is some are easier to explain than others. Let's zero into something more tactical. Candace had brought in around clinician experience in that space, and that being soft. While you can't use where you can't use causative language, like I did this and it caused this, you can use correlationary language, right? You can say, "Hey, we are looking to improve the experience of the nurse through clinical documentation, easing the burden of that documentation." And then, oh, look, it appears that we have improved the employee satisfaction score. We all call it something different, but that's the generic term. And then, oh, we also see that we've reduced turnover in our nursing population. Well, I certainly can't say that us creating a more streamlined documentation experience in the EHR caused that, but we could say there's correlation as I look at that occurring over time. So that's more on the soft side, but you can still get to something that is financially impactful, which is nurse turnover. And then there could be something more direct. There's technology out there, not saying that Common Spirit's engaging in that technology, saying that we are or we aren't. But there is technology out there that assesses whether the patient is turning. It is literally an AI tool that looks to see if the patient's turning. It directly connects in with the technology to document said turning and then alerts the nurse if the patient did not turn, or the care team, I should say. So then we could, potentially turn that patient. Again, new technology that is out there, that is available. And then therefore we know turning reduces HAPIs, right? Hospital acquired pressure injury. So did we see with new technology a reduction in new HAPIs, which is what we want, and therefore there are dollar signs attached to what treatments are to HAPIs. So if we have saved money by not having to treat HAPIs because the technology has improved that turning experience for the patient. So again, a couple clear examples around, when we're looking at ROI, we can tie to financials, sometimes more directly, sometimes more corollary.
Yeah, and I'd say, Mike, that, that's right. The soft ROI piece, though, has to always be, it will always be part of the medical industry. But I can tell you, when my most difficult provider and biggest curmudgeon, his picture is in the dictionary by the word curmudgeon. Once he gets ambient scribing, sends me a nice note, and then becomes a positive contributor around everything around ambient scribing. We've had a positive impact.
Yep.
I mean, just to piggyback off of what Steve was saying, part of it is, yes, you have to have an ROI and you have to be able to figure those things out. But again, ROIs initially are just, they're just magic. It's just the magic of accounting, right? Like you can sort of manipulate things a little bit, but part of it is also just you have to keep up, right? You have to maintain. Some of this technology is just to keep the status quo. We think about when we just a short few years ago started having clinicians that we'd interview say, hey, what's your PTO policy? What's your compensation? Do you have ambient? Right? That was a new question. And so if you don't have that, you're not maintaining. So sometimes it's just the cost of doing business. I think to be able to maintain some of these things, I can make very pretty pro formas. But I think just to be able to say, yes, we have this, we have tools for nurses that make it easier. We have tools for clinicians that make it easier, because you have to be able to maintain. So I also still get a little palpitation since you guys you had 5 instances of Epic. That still bothers me a little bit right now. So I might need to seek some care later.
Yes, it's quite stressful and costly at the same.
There's probably an ROI for that application rationalization right there. But as we continue to talk about ROI, and as Josh mentioned, our world's a little bit different in that we are very much an IT integrated informatics team. And so we also talked about our 2026 future and plans have a lot of growth. And when we think about growth, ROI in that space is very different when finance calls and says, hey, IT, fill in your ROI for this new service line or this new location, right? That's a little more straightforward in what it's going to cost to bring up clinical services in specific locations and how we project what we believe the volume and contribution margin for that would be. Very different when we sit around a table with nursing leaders and think about how do we deliver technology that adds improvement. And so we really look to align early on what's our problem statement and then really focus on defining the metrics that matter. It's really easy to say we have a problem. It's a lot harder sometimes to really drill down into what are the metrics that matter and what illustrates that problem and how do we really measure improvement. And then, running those small pilots. Sometimes we are, I would say, a victim of some pilot purgatory. We get stuck sometimes. And so making sure that we have sort of those hard exits defined with those metrics so that we can show the improvement or not and decide to exit at that point. So lots of it really depends on what we're doing, I think, when we consider hard ROIs like our, reduction in agency spend or decreased readmissions or avoiding readmissions, and then your soft ROIs, like our focus on reduction of incidental overtime or decreased documentation time, decreased time from observation to documentation, et cetera.
Amanda, you brought up a great point. I love that you just called it what did you call it? Pilot
Pilot
purgatory.
purgatory.
I love that. I may have to coin it and then footnote that to you. But laughing aside, the reality is, where do we bring into these large health systems? Because we're all in a very varying level of large, right? Multi-hospital, some multi-state. What's that threshold of what success looks like and doesn't look like? What does pivoting look like? And then what does we've exhausted what we needed to do and it's time to cut? Right? Know when to stop, know when to withdraw. So that's interesting when we are talking about some of these new technologies and identifying what those metrics are up front. Because if you do not identify the metrics up front, then you can even more so get stuck in the pilot purgatory, as opposed to saying, we've exhausted, we've pivoted, it is now time to stop because we aren't seeing what we originally planned. So I appreciate you bringing that up.
So, um, one of the drivers for us is also that our true north is like, what are the strategic initiatives? What are our stated goals? And this year, for the first time, we really got them relatively locked down in January, as opposed to other years where we're spending like 2 months. Like, what are our goals this year? We had a semi-painful conversation, Amanda and I, with our IT leadership team, where we went through our list of things I call them the barnacles of projects, because they're a row on a smart sheet, but are we really ever going to do it? And does it
Mm-hmm.
actually map up to one of the core initiatives?
Mm-hmm.
And there's a lot of things on that list that would make a lot of people happy, but they don't actually map up to the core mission of you're going to deliver on this operating margin, you're going to improve the mortality index with Vizient by X. So I think we're this year going through the painful realization that if it really doesn't map, it doesn't happen. And
Mm-hmm.
that's actually another version of ROI, because it doesn't get any bonus points if it makes a clinician's life better. Again, if it doesn't map up to that sort of big list that we've created in the sky. And moments before I was here, I was presenting kind of how we had coalesced things into core initiatives. So I just think ROI is going to be increasingly measured also in
Mm-hmm.
deliverability to system goals,
Mm-hmm.
right? It's not an individual dollar amount anymore. It's like, are you going to further something that the institution decide we are doing this year or we are doing in this 3-year arc. If it doesn't meet that muster, it's not going to go forward.
Mm-hmm.
I think those are super hard conversations too, because in general, 99% of all these things that people bring to us, they're good ideas, right? They're good ideas and they make sense and they help a patient or they help a clinician. But the scale is so small sometimes, and the lift is so high that it doesn't really make sense, or it doesn't meet those system ideas, those system pillars that you really need to focus on. And sometimes that's just a tough conversation to say, yes, your idea is good, but we're not going to do it. But it's really critical.
And I'm just going to add another
Yeah.
on this, a spin on this as well too, because I think we also avoid the conversations on kind of that medium level bucket of work that needs to happen. But we keep kicking the can down the road, and it's just sometimes optimization, our foundational structure as it relates to the EHR. As we unpeel and discover some things of the rationale of why something was built a certain way, because then it makes it very challenging to layer new technology over it. Some of the bells and whistles or, that's reliant on that foundation. So that's another focus that we kind of carved out a little bit of a lane. Yeah, it might roll up, but it's in a different way. It's kind of existing work, but we need to really optimize this middle bucket of, work that's really heavy, but it doesn't rise to the top of some of it being resourced by, like our EPMO resources and stuff. So we kind of struggle with like trying to get the right people to get rallied and move this work because, at the end of the day, it will help us as we layer some of the new technology or the AI that, is driven off of this foundation. So sorry, Steve, I kind of cut you off there.
No problem whatsoever. I can't see your lips starting to move, so no problem. But hard conversations with makes successful healthcare companies successful, right? Because there's always so much money. There's always so much retained earnings, right? And you have to do the things that drive the mission forward, and the mission is served by the strategy. And if you don't have any strategy, there is no mission, there is no money, there's no provision of the core service you want to provide. So, those tough conversations are what we do and what we're supposed to be good at. And I think anybody who's listening to this, you have to get comfortable with uncomfortable conversations because it's where we are today. There's only limited money, limited resources, and we're going to have to make choices. And some will be good, some will be bad, some will be ugly, right? But we have to make choices.
I think that's actually a great segue into having each of you share how you help drive that interdisciplinary communication that's key to all of this, those tough conversations, the team decisions that have to happen. Candace, do you want to start?
Sure. I would say in our organization, we've started a governance structure probably over the last, Dr. Anderson, about maybe 5-6 years.
Yeah.
That really kind of helped organize the framework in partnership with our operations. So one example is for new technology, designing that framework and structure to navigate new technology into the organization so that we can all be on the same page. There's nothing worse than getting surprised by operations signing a contract and then coming to IT and like, oh, by the way, this has got to, get put in the next 2 months, or we're told that it's easy IT lift, but at the end of the day, it's not. So we've done an extensive effort around, coming together. And so we do have those regular conversations with our operational folks in technology and informatics and analytics. So it's really coming to the table, have those conversations. And then again, as I alluded to with the core platforms, kind of putting that stop sign. Have you checked with our core platforms? Can we do that? Are you aware of it? So having that established in place kind of has helped drive that. We're still kind of in the infancy, but I think just over the past year, it's worked really well in that realm with new technology. But as it relates to some of that medium, smaller stuff, that is also governed as well too, and that cross collaboration. Just to ensure, if the nursing division has a great idea, but yet it might impact Dr. Anderson's ambulatory, we have that way of cross communicating and, maybe stopping the train before it gets too far. So we try our best, but it's not perfect, but we continue to refine that process with our governance and partnership with operations and IT and analytics. Dr. Anderson, if you have anything else to
No,
add?
I think you said it really well. I mean, I think it's just really about being intentional about it, having those
Mhm.
intentional conversations, being present where people are at.
Yeah, I appreciated that. And governance is can be a powerful way in delivering solid direction, right?
Mhm.
Having what we call the three-legged stool, because it's CIMI together, and then IT, and then our operators, right, which would be the host of clinicians as well as our administrators. And what I will say though is there can be, I'm going to use Amanda's word now, governance purgatory, or analysis paralysis inside of governance, right? So making sure we have the right folks at the table, and then with what I would consider clear, true north direction setting on how do we make decisions in a decisive and meaningful way so we don't get stuck in those spaces so that we can drive to the outcomes of where we need to go. I
I
will
would,
also
oh, go
go
ahead.
Yeah,
ahead.
Mike,
Go ahead, Steve.
I would say, this is a clinical business we're in, right? So once you become informatics, so you know the clinical, you're no longer the clinical expert, right? So we got to bring operations, we've got to bring uh, clinical leaders, we've got to bring IT all to the conversation before you get pass go on the conversation to make sure we understand all the values that can be brought and we make the best decision clinically, operationally, and fiscally. And that's the only way to approach it and be successful. Even then, sometimes you're going to get it wrong. I'm sorry about the truck noise around me. It's, yeah.
Amanda, sorry about
I,
that.
I think governance for us looks a little different, in that we have historically been um, geographically in one space with both our hospitals and our medical group.
Hmm.
And as we continue to evolve and we work in 2026 to onboard some of our very rural facilities onto common tools, it really, we're now at a point that it gives us a good opportunity to reevaluate governance as we grow in system thinking in a different way, which is new for this organization, I think.
Yeah, we should have a governance conversation. That's another opportunity, Tina, for us in the future. And the reason why I say that, Amanda, as our systems grow, meaning our health systems, we, give birth to new hospitals or acquire new doctors' offices, that growth and then having the helping folks get to the systems mentality to make decisions that are for the greater good, I would say becomes a unique challenge because individuals focus on their individual needs. And so, how do we retrain them and bring them to the table saying, okay, we have to shift our mindset on how we're making decisions. So, I think that's a great conversation for future because small to medium to what I would consider very large, and governance likely looks very different in them.
So not to be the contrarian, because and it's interesting because I'm really kind of split right down the middle on this one because I strongly believe in this theory of shared governance, that, you know, power to the people unite, we've got to have individual units, the actual users of the tool have a voice. At the same moment, again, I'm going to come back to the idea if it doesn't map to something that we're supposed to be doing, all the governance in the world isn't going to solve for that. So I think to do this right, it is an engagement with our strategy leaders in an organization
Mhm.
to be so explicit about this is what's important this year. Within that, you can fine tune the details to say, uh, a good example, mortality. Like we're trying to get to a very, very specific, I'm very proud of the fact we're now like top decile, whatever, but we want to keep going. What am I going to do on this nursing unit that's within our control to manage or decide that in the end actually results in a change in mortality? It might be that, yeah, I'm going to avoid more CLABSIs. I'm going to do something that maps to it. But I think it's a challenge to have end users understand an end goal that then allows them to do true governance. Because otherwise, I call it untethered governance. It's like, yeah, I want to do the things that are going to make it get great for me to come to work every day. That is not going to move a mortality needle. And I know it comes across sounding harsh, but um, you could governance yourself to death if it's not within a guardrail or framework.
Hmm.
Sorry, Amanda, that doesn't sound. Please
I
don't
can't agree
report me
with
to
that.
the Magnet Committee.
No, but this actually match perfectly because where the work is done is our frontline users, and they have to be part of the conversation because they know how things happen. They know what will and won't work, and so you're spot on. We can't just meet with leadership. We have to have the frontline people who are willing to take time and participate in the process.
Governance is definitely a team sport. Even though I joke about governance being a four-letter word, I do think it's a super important framework, and I love that all of you shared your each of your approaches to it, because it's a real life thing that I think a lot of teams struggle with, and more importantly, how to do it well. So, with the last few minutes, since we're on this topic, why don't we talk about trust a little bit and how to build that with your frontline clinicians in your governance discussions?
I'll jump in on that one. We are Magnet as well too, so we're really aligned with the shared governance structure. So in our nursing role, we have a nursing informatics council that has been very well attended. A lot of back and forth ideas and discussions, hard discussions, even from our clinicians back to us that, it's like we thought things were a great idea to put out there and it does get shot down. So I really enjoy having that shared governance opportunity. In terms of kind of taking that a little bit step further, what we're doing in our organization, we've designed a nursing informatics fellowship program in-house where we can engage our frontline staff. And again, we're starting small. And so next year for the next cohort, we're going to expand. But engaging our frontline nurses in, the concepts of informatics and what it is like to navigate informatics kind of behind a peek behind the curtain. And so we're sharing those concepts and then in parallel, allowing them to do a real life project. Again, kind of going back to what you mentioned, Dr. Lee, we really kind of have to look at balancing. Yeah, sure, we got our large scale strategic projects and initiatives, but we always allow for a little bit of, some of that lower level or, like nice to have things. But we're engaging with our frontline staff to do that work. So that's been really exciting to see, and they get a flavor of what it's like to navigate informatics from a frontline perspective. And then they can take that back and, disseminate what that's like and what's the next thing they can do that maybe is less IT or, technologically heavy, but there's also process improvements that they can do on their own that would be a lower technology lift. So that's kind of what we're starting to see out of that. So that's been really wonderful.
Yeah, trust is difficult to gain in the healthcare environment sometimes, but I think it involves being personal with the folks that are asking for things, being honest with them, keeping track of, involving them. Don't try to hide what's going to happen from them. Respond to them. So, in Epic, you have the thumbs up, thumbs down comment, or you have an alert, right? Do you actually monitor that? It's hard to do and respond to that user with what you're going to do or not do. Do you follow up? That takes time. But once you start doing that and then you're going to be consistent in your response and you're going to tell them what's up, straight up, that's how you over time develop trust. It doesn't just come. You have to earn it and keep earning it every day because they have so many things going on and they're so busy that asking me a question, they don't have time for me to give them 17 paragraphs. They want two sentences that tells them where we're going. And they have to trust that those two sentences mean what I said they mean, what they actually say.
It's, I call it the trust piggy bank. You make deposits and withdrawals, right? In the space. And trust is developed over time through consistency and action. And then there are things sometimes that are outside of the control or unintentional that may momentarily erode that trust. So then you have a withdrawal. And so to me, trust is dynamic. in nature. And I'm not going to repeat what Steve and Candace had already said because it's all part of that. But really, what I look at and trust and I work on every day with my customer and my team is exactly what we've discussed. Transparency where we can, consistency in message delivery, and then where it erodes sometimes is when we have to pivot or we can't deliver on something we said we're going to deliver. You still go in with the why, but we know we're doing withdrawal then, so I have to work, extra hard to put some deposits back into it. So it is certainly a dynamic term.
I think that's a great description, Mike, and would agree. Building of that trust it is really multi-factor, right? It's about co-designing solutions and getting viable input from the people who are going to use the tools, whether that's through shared governance councils or other forums, but then leveraging real transparency, both with wins and with misses, engaging with them as they're using the tools through things like shadowing and listening. And then having a process to fix stuff when you need to, right? Because I think trust is really a byproduct of those shared decisions, of that transparency,
Mhm.
of visible outcomes, and the ability to make corrections when you need to.
Yeah. Do we have any questions from our folks that joined us today? I feel like we've done a lot of talking. We would love to have questions in the last couple of minutes.
I prompted for that. Thanks, Mike, for thinking of it. And I've seen some commentary come through, but not necessarily any questions. So
Okay.
since we have just a few minutes left, any last words of wisdom or final best practices to share based on everything we've covered so far today?
I do want to reflect on something Amanda said about trust and really kind of hearing people. We have this initiative which is called Speak Up, like making sure that people really have voices. And I don't think we as healthcare institutions live up to that as much as we wish we did. But one way that helps is really that willingness to, I call it dwell at the bedside. Almost like if you have an attitude in the best possible way of acting like a joint commission surveyor and do a tracer with an end user. Okay, like what are you going to do next? Show me how you're going to schedule this patient for this oncology infusion. Where do you get confused? It's painful sometimes to see how hard it is to use the very tools that we think make it better.
Hmm.
But the trust is when you're willing to, I call it dwelling in the sadness. Because if you don't actually see how hard it is, you can't possibly be inspired to fix it. I'm I'm kind of lucky in the sense that I'm also a little bit part of our clinical engine here at TMC. And so, I have an in basket just like every other physician has an in basket. And that's probably true for, a
Mhm.
lot of the people who are in the CMIO or CHIO role. And I just feel like if we want to do the right thing, we have to live the life of what we've built because it's the only way we see it. That's not meant to be a Debbie Downer statement. I think it's just a way to get to real. I depressed everybody.
No, I think that's
I
a
was gonna
great
say
point as we
purgatory,
bring in.
dwelling in sadness. Like
Yeah.
there's a lot of fun things here too. Like we're fun people. We can, we do good stuff. And I think that is the other thing. Is just as soon as you have a win, you got to celebrate it, right? Like as soon as you do something good, celebrate it because it might be a while before you have another one. So I
Mhm.
think we do that quite a bit. I mean, we've had like in one of our virtual programs, we've been kind of overwhelmed with some things with patient demand this month, but like when we have a really good day, like we talk about it and we have fun and we if somebody hits 21 patients, they have to yell out blackjack on our team site. So there's certain things where you can do and just really make sure that you're having some fun at the same time.
Yeah, I agree. And Josh, what you outlined was a Gemba, right? That's essentially what you're like, how do I go and live where the work is being done to get the insights that we need to improve the experience? So, yes, we certainly have opportunity in that space in healthcare overall, not any necessarily in particular a system here today, but healthcare overall, we all should be Gemba walking.
And I think as we look at 2026 and the work ahead of us, if it doesn't align to strategy, or if it doesn't make it safer, simpler, or more human, we should rethink it.
Yep, agree.
What she said.
Amen to that.
That's amen. I think that's our closing statement, Tina. You go, Amanda.
I love it. That's a great high note to end on. And to be able to say thank you to all of you, Amanda and Josh and Mike and Steve and Candace and Matt, for spending your time here this afternoon and, talking through the differences and realities about all of this today. For
Yeah.
those who have joined us, please remember to register for your CEs. And for those friends who were not able to be here, we will be publishing the link out on our website in the next few days. Please also go out there and register. We've got part 3 coming up, where this team will reconvene to continue talking about AI enablement and governance, our favorite topics these days in 2026. So thank you, everybody. We wish you a great afternoon.
Thank
Bye,
you.
guys.